Okay, so we care about antifungal therapy because it affects 1 billion people worldwide with both superficial and invasive infections. We care about antifungals because 1.7 million people die per year in terms of the immunocompromised patient population from invasive fungal infections. We have millions of fungal species, but 300 of them can cause disease in humans. 20 are relatively common pathogens, and you can see the numbers there yourself for candidiasis, aspergillosis, and cryptococcus as far as high incidence, high killers. So in terms of our enemy, we need to know where to attack our enemy, right? So when we're talking about antifungal therapy, we're going to start by talking about the polyenes. Specifically, I'm going to focus on amphotericin B and lipid formulation predominantly, but nystatin is also a polyene antifungal. They attack directly at the cell membrane. We're going to talk about the azole antifungals, which inhibit ergosterol synthesis, which is a critical component of the fungal cell membrane. Terbinafine also works via this mechanism. And we're going to discuss the echinocandins, which interfere with cell wall synthesis. For time purposes, I'm leaving off flucytosine, which inhibits nucleic acid synthesis. So this is conventional amphotericin B, deoxycholate, fungizone, OG amphotericin, right? This is a very potent antifungal fungicidal agent that we've had available to us since the 1950s. We're active against yeast and molds. Probably more important to talk about which fungus it's not active against. So it's not active against Candida lusitaniae, Aspergillus terreus, Pseudosporum species, Trichosporum begillii, and amphotericin resistance is reported in some isolates of Candida auris, and unfortunately, increasingly in Fusarium as well. So we knew amphotericin as amphoterrible, predominantly due to infusion-related reactions and nephrotoxicity, right? So the infusion-related reactions like the shake and bake syndrome, mostly fevers, chills, rigors, although more severe cases, dyspnea, hypoxia, nausea, vomiting, headache, arthritis, myalgias. We've pre-medicated with acetaminophen, diphenhydramine, hydrocortisone. We have rescued patients who develop rigors from amphotericin with merperidine, which is not a fun drug, morphine or hydromorphone. We've monitored our patients very closely for drug-induced nephrotoxicity. We've tried to reduce that with saline loading, 250 to 500 mLs, normal saline, pre and post each dose, ideally. We have to monitor our patients for electrolyte abnormalities, particularly potassium, magnesium, some bicarb wasting as well. These patients often need potassium chloride supplementation, often maintenance therapy, plus or minus amiloride. It's a potassium-sparing diuretic. And just to be aware that with prolonged therapy, we can see reduced production of erythropoietin, which can result in anemia as part of its nephrotoxicity. So while I was in pharmacy school ages ago, the lipid formulations of amphotericin B were being developed in order to increase drug delivery to the site of infection, mostly to reduce toxicity and thereby allow us to administer a full course of therapy to these patients. So initially there were 3 lipid formulations available, liposomal amphotericin B or ambisome, amphotericin B lipid complex, Abelset, and amphotericin B colloidal dispersion or Amphotec. At this point, I think we have a winner of the lipid wars. That would be liposomal amphotericin B or ambisome. Amphotec is not available. It has not been available for quite some time. Abelset has recently dropped off the market. We'll see if it comes back at some point. So in terms of infusion-related reactions, the short version is that Amphotec actually had the highest incidence of infusion-related reactions, higher than conventional amphotericin B, which is one reason that became very unpopular very quickly. Abelset has a very comparable incidence of infusion-related reactions to conventional amphotericin B, and ambisome has the lowest incidence of infusion-related reactions. Although I do need to briefly mention that there's such a thing as an atypical ambisome infusion reaction, which is probably patients who are specifically intolerant to the lipid formulation of AmBisome. And while it's rare, it's very dramatic when it happens. So within minutes of infusing the drug, the patient's complaining of chest pain, dyspnea, hypoxia, or they have severe abdominal flank or leg pain, or flushing or urticaria. It's immediately stop the AmBisome, administer IV diphenhydramine. Interestingly, in this case series that first reported this, they talked about pre-medicating subsequent doses with diphenhydramine, doses up to 1 milligram per kilogram, which I personally feel uncomfortable beyond 50. So that might be used as part of the pre-medication regimen for future doses, as well as like a slow initial infusion rate. We often would change to a completely different formulation, such as from AmBisome to Abelset. In this setting, patients were often reluctant to receive the same drug again. However, currently that would not be an option. Nephrotoxicity, really this is the hallmark of this entire group. So all three of these agents had lower incidence of nephrotoxicity than conventional amphotericin B. But in the Wingard trial, which actually looked at AmBisome compared to Abelset, they not only saw that AmBisome had a lower infusion reaction rate, so it had a lower nephrotoxicity rate. So AmBisome seems to have a lower incidence of infusion-related reactions and nephrotoxicity, even than the other lipid formulations of amphotericin B. So conventional amphotericin B very rarely used anymore, typically doses of 0.5 to 1.5 milligrams per kilogram per day, higher doses for mold infections. Abelset only been studied at 5 milligrams per kilogram per day. Liposomal amphotericin B or AmBisome has been studied at a wider range of doses, possibly due to superior tolerability. So we do know that for aspergillosis, 3 milligrams per kilogram per day was as effective as 10 milligrams per kilogram per day, but less toxic. For otherwise, the package insert recommends 3 to 5 milligrams per kilogram per day. But for fusariosis or mucormycosis, there certainly is experience using higher doses than 5 milligrams per kilogram per day. 7.5, 10, upwards of 15 milligrams per kilogram per day have been used, although no one knows the magic number for when efficacy is maximized, toxicity starts to become more of the problem. There's very limited data on using AmBisome prophylactically, but doses of 1 mg per kg per day, or 10 mg per kg every week, or 15 mg per kg every 2 weeks have been used, and nebulized AmBisome has also been used to reduce the risk for invasive pulmonary aspergillosis. Moving on to the azole antifungals, Fluconazole and Itraconazole, Voriconazole, Posaconazole, and Isavuconazole. What I will say about the azole antifungals, they all have oral and IV. They all have oral formulations, at least, if not IV formulations. They have lots of issues that keep pharmacists quite busy, and we will talk about those. I will mention in terms of spectrum activity, the azoles are fungistatic against Candida and fungicidal against mold, those that have activity against mold, right? So fluconazole, of course, does not have activity against mold. Voriconazole has activity against Candida and aspergillosis. Posaconazole and Cresemba should add in the mucormycosis. Okay, so fluconazole, I think we're all pretty familiar with. It's predominantly used for Candida species. It is used in maintenance therapy, secondary prophylaxis for cryptococcosis. A couple of species that we have to think about: Candida krusei is intrinsically resistant to fluconazole, while Candida glabrata likes to produce these efflux pumps, which can pump out fluconazole and sometimes other azoles as well. So it may be Candida glabrata can be resistant to fluconazole or susceptible dose-dependent SDD, which is the best case scenario for Candida glabrata and fluke. Fluconazole has dose-dependent activity, so we can get by using doses as low as 100 to 200 milligrams per day for relatively mild mucocutaneous infections, but for more systemic infections, we want to load with 12 milligrams per kilogram or 800 milligrams times 1, and then 6 milligrams per kilogram or 400 milligrams Q24 thereafter in adults. When we're treating a Echinocandin infection with fluconazole, we're going to need the higher maintenance dose, so typically 800 milligrams per day or 12 milligrams per kilogram per day. Excellent bioavailability. It also has good penetration into the eye and the CNS. It is a mild to moderate inhibitor of P450, 3A4, 2C9, and 2C19. But if you ramp up the doses, you can see more clinically significant drug interactions. It's also, unlike the other azoles we're going to talk about, it's dose adjusted for renal dysfunction. We're going to talk about the extended spectrum azoles, Voriconazole, Posaconazole, and Isavuconazole, zonium sulfate. So Voriconazole is considered to be the drug of choice for the treatment of aspergillosis, or one of the drugs of choice, I would say. But this all came from this study of 277 patients with invasive aspergillosis. This was a randomized controlled trial between Voriconazole and conventional amphotericin B. And Voriconazole was much better tolerated, as you might imagine. The median duration of therapy with Voriconazole was 77 days, but amphotericin B, the median duration was 10 days because 80% of them had to be switched to other antifungal therapy, which was almost exclusively due to nephrotoxicity. So as a result, Voriconazole had a higher success at 12 weeks and, more importantly, survival at 12 weeks. So based on this, it's considered to be the treatment of choice for invasive aspergillosis, but we don't have a head-to-head comparison with lipid formulations. It's also FDA approved for treatment of candidemia, esophageal candidiasis. It can also be used for Cidofovir and Letermovir. It's a great drug for that. For fusarium infections, it's FDA approved for intolerant or refractory patients. Unfortunately, as I mentioned earlier, we're seeing more and more multi-drug resistant fusarium out there, not just Voriconazole resistant, amphotericin B resistant, azole resistant across the board is becoming a more and more common theme, unfortunately. In terms of toxicity, Voriconazole tends to follow the rule of 30, which means about 30% of patients will experience some kind of usually mild to moderate visual disturbance. Usually occurs about 30 minutes after the drug is administered and typically lasts for about 30 minutes, although high interpatient variability. This can be, altered or enhanced visual perception, blurred vision, color vision changes, like an aura around objects, potentially photophobia. Patients should not drive at night for the package insert while on Voriconazole, and certainly not if they notice any change to their vision. As I said, usually mild, especially associated with IV Voriconazole infusion, especially if it's infused too rapidly, and may resolve spontaneously. It rarely prevents patients from continuing therapy. The site of this appears to be the retina, so based on electroretinography, we know that within 14 days after discontinuation, those electrical signals normalize, so you can reassure your patient this is not a permanent effect. Separate issue, though, is more CNS with hallucinations and encephalopathy distinct from these visual issues. And this was reported in 13% of patients in that invasive aspergillosis trial that I just referenced. And interestingly, it does seem to correlate with elevated Voriconazole levels, which is part of the rationale for therapeutic drug monitoring with Voriconazole. We do have to look out for dermatological side effects with Voriconazole, mostly mild to moderate, but there are cases, Stevens-Johnson's, TEN, erythema multiforme. Also have to be aware that this drug is a photosensitizer, and patients need to be warned of that. And we certainly need to monitor patients closely if rash develops, because Voriconazole discontinuation may be necessary. The azoles have the potential to be hepatotoxic, and Voriconazole is certainly no exception. You're going to want to baseline LFTs and monitor throughout therapy as well. Voriconazole is a QTc prolonging drug, as is Fluconazole and Posaconazole. Voriconazole, interestingly enough, can cause fluorosis / periosteitis with symptoms of musculoskeletal pain. This has been seen with patients on prolonged therapy, usually for months, and associated with the fact that there are more fluoride ions in Voriconazole, 3 fluoride ions per molecule. So you get about 65 milligrams a day of fluoride. It's actually more than you see with Posaconazole, dramatically more than you get with treated tap water. There are uncommon reports of anaphylactoid reactions during Voriconazole infusions, but these are far less common than we would experience with either conventional or liposomal amphotericin B. Excellent bioavailability, although decreased absorption if you take it with a fatty meal. So patients should not eat for 1 hour before and after each dose. Absorption is not affected by pH. It has excellent volume distribution, also has very good CNS and ocular penetration as well. In renal insufficiency, its clearance is not affected. There's some concern about the cyclodextrin solubilizing agent, which can accumulate in renal failure. However, we have 4 retrospective and observational studies that have failed to show an increased toxicity in patients receiving IV Voriconazole from a toxicity standpoint, especially nephrotoxicity based on some animal data model. So we typically do not consider this to be a true contraindication. In terms of Voriconazole and hepatic dysfunction, patients who have transaminitis, that does not correlate with clearance of the drug. However, Voriconazole could potentially aggravate that transaminitis, so monitor carefully. Package insert does mention elevated Child-Pugh scores, which are based on scoring for cirrhosis, and they talk about consider a 50% dose reduction for Child-Pugh score A and B. What I will say is the Child-Pugh score are not validated in patients with acute hepatic dysfunction, and typically that's what we are encountering when we encounter this in our cancer patients. It's often chemotherapy associated hepatic dysfunction. So I think honestly, therapeutic drug monitoring is key in those patients. Voriconazole is metabolized by CYP2C19, predominantly, to a lesser extent by 2C9 and 3 and 4. Has saturable metabolism, which means nonlinear pharmacokinetics, which means the higher the concentration, the longer the half-life. Voriconazole also inhibits CYP2C19, 2C9, and 3 and 4. So, which is similar to what you might encounter with fluconazole, but Voriconazole is a more potent inhibitor. In terms of the CYP2C19 genotype, there is a significant difference between what kind of racial population you're talking about, right? So patients with a Caucasian, white ancestry, African Americans, and Hispanics tend to be more rapid metabolizers, whereas people of Asian ancestries tend to have a higher incidence of being poor metabolizers. We actually utilize this for our acute leukemics who come in who are going to need antifungal prophylaxis, often with Voriconazole. And so if we have patients who are ultra rapid metabolizers, we avoid Voriconazole and use an alternative agent such as Posaconazole, Isavuconazole, or microfungin. For rapid metabolizers, we use a higher starting prophylaxis dose of 300 milligrams twice a day instead of 200 twice a day. And our poor metabolizers, we rarely push them beyond 200 milligrams twice a day. Voriconazole loading is semi-optional, right? So if you're using it in an acute situation like a candidemic patient or a patient with fusarium that's where things are acutely worsening, or for chest pain for aspergillosis, then you're going to want to load these patients to get the therapeutic concentrations more rapidly. If you're dealing with prophylaxis or you're dealing with a patient who has a nodule that was seen on a CT scan that's completely asymptomatic, it may not be necessary. The only downside with loading is if you're very aggressive with it, you might overshoot and have some CNS side effects, which can make patients less desirable to continue on therapy. I will say the other azoles, the loading doses are not optional, which we'll talk about as we get up to those. If your patient has a history of previous Voriconazole levels, use that for your dosing, to guide your dosing. But most patients, you're going to, for invasive fungal infections, you're going to use typically the load would be 400 milligrams or 6 mg per kg, Q12 times 2 doses, and then 300 milligrams, 3 to 4 mg per kg, Q12 thereafter. If you're using a weight-based approach, consider adjusted body weight for our obese patients because it's easy to overshoot these patients. In terms of antifungal prophylaxis, as we mentioned before, usually 200 milligrams twice a day or 300 milligrams twice a day thereafter. In terms of Voriconazole therapeutic drug monitoring, it is definitely recommended in patients who are expected to receive more than 14 days of therapy. We obtain a Voriconazole trough on day 5 to 7 of therapy. For prophylaxis, we shoot for a level 1 to 5.5. Basic fungal infections, we like that trough to be at least 2. And this is important both because we have reduced efficacy with low levels, and we have increased toxicity, mostly neurotoxicity with high levels. Because this drug has nonlinear pharmacokinetics, we get more of a bang for our buck with our dose adjustments. So this is why we typically use a 25 to 50% dose adjustment, as you can see on the chart. In terms of other drugs affecting Voriconazole metabolism, enzyme inducers are not a lot of fun, right? So first off, don't try to use rifampin with Voriconazole, Posaconazole, or Cresemba, and we'll chew it up. Phenytoin and rifabutin are theoretically possible, but really complicated because Voriconazole inhibits phenytoin and rifabutin metabolism, meaning you need to lower the dose of those drugs, and they induce metabolism of Voriconazole, meaning you have to increase the dose of your Voriconazole, and lots of therapeutic drug monitoring. Other enzyme inducers, such as carbamazepine and phenobarbital, probably have a similar effect on Voriconazole metabolism. We have less data on that. We do know that there's a relatively mild to moderate effect of omeprazole, which is a CYP2C19 enzyme inhibitor, on Voriconazole concentrations. Usually doesn't require Voriconazole impaired dose changes. Voriconazole also inhibits omeprazole metabolism, so we usually cap that at 20 milligrams a day. Long list of Voriconazole drug interactions interfering with the clearance of other medications. That first row, those are all 3A4 substrates and QTC prolongers, so that's a double whammy with Voriconazole. Fortunately, some of those drugs are no longer on the market, partly because of this reason. Voriconazole inhibits the ergot alkaloid metabolism. In terms of immunosuppressants, cyclosporin, tacrolimus, and a major drug interaction with sirolimus. But warfarin is also a major drug interaction, potential to affect fentanyl, oxycodone more so than methadone. Our statins we have to think about because of risk for rhabdomyolysis. Although cravastatin and rosuvastatin are good options as they're not 3 or 4 mediated. Felodipine is an example, sulfonylureas. A lot of chemotherapy agents ranging from big alkaloids, busulfan, tyrosine kinase inhibitors, venetoclax. You always want to make sure that it's not an issue with your chemotherapy. Also a number of antiretrovirals. Switching over from Voriconazole to Posaconazole, which is FDA approved for prophylaxis of invasive aspergillosis and candidiasis in high-risk patients. So we're talking about our MDS AML patients that's post-induction chemotherapy and our allogeneic stem cell transplant patients with graft-versus-host disease. Initially approved was an oral suspension at 200 milligrams, 5 mL, 3 times a day with meals. A much better formulation, delayed release tablets, 100 milligram tablets, 300 milligrams twice a day on day 1, followed by 300 milligrams daily thereafter. We have an IV formulation with the same dosing. It should be given via central venous catheter. You can go with 1 dose peripherally, but we see thrombophlebitis if you try to give multiple peripheral IV infusions. There's a relatively new formulation out there that I've never used called Maxifil Powder Mix. It's really FDA approved for pediatrics weighing less than 40 kilograms. It has to be reconstituted within an hour before use. You have to use their provided notch tip syringes to prevent aggregation of the suspension during preparation. Our wholesaler doesn't even carry it. Just to be aware that Posaconazole has been studied versus Voriconazole for invasive aspergillosis, and it is a very appropriate alternative. They had equivalent mortality in both groups, and the Posaconazole had a lower incidence of treatment-related adverse effects, mostly less visual, CNS, and hepatotoxicity. Not enough to say that it's completely taken the crown from Voriconazole, but it's certainly an appropriate alternative to Voriconazole. Posaconazole is predominantly metabolized by UDP glucuronidation. As a result, dose adjustments for hepatic dysfunction typically are not necessary. Unlike Voriconazole, inhibits CYP3A4 only. It's got excellent distribution, although not as good a distribution to the eye and the CNS as Voriconazole. And it has a substantially longer half-life in the 25 to 36 hour range. And as a result, you want to give that loading dose, otherwise you're going to have subtherapeutic concentrations for an excessive amount of time. Okay, so Posaconazole suspension. Spent a lot of time dealing with this back before the delayed release tablets became available. It's not a good formulation. I don't advise using it. You're dependent on gastric pH. You're playing around with adding ginger ale or other acidic sodas to improve your absorption. You're avoiding PPIs. You're considering giving the smaller doses more frequently due to saturable absorption. Posaconazole bundles were a thing. Even we throw in like Insure Plus if they can't take a full meal. We throw vitamin C to try to improve the absorption. Just avoid it. We have better formulations now. Both the delayed release and IV formulations at the recommended doses are far more. First off, they more rapidly achieve therapeutic concentrations, and they are far more reliable in terms of achieving therapeutic concentrations. They're not perfect, however. So while we don't routinely recommend therapeutic drug monitoring for Posaconazole prophylaxis, we do recommend it for patients who are going to require Posaconazole for treatment, or potentially patients who are morbidly obese, have severe diarrhea, etc. We want a trough level, although it's not as critical as Voriconazole to get an exact trough level because of the longer half-life. Prophylaxis greater than 0.7, basic fungal infections greater than 1. So we will occasionally need to bump up someone's dose from 300 milligrams a day to 400 milligrams per day. Rarely any higher than that is necessary, unless we're pushing, we're treating a particularly challenging case and we want to push our Posaconazole concentration to 3 or higher. This is it's a new approach that can be considered in the salvage setting, especially if Posaconazole MIC is in the 0.25 to 0.5 range, which previously by UCAS standards would be considered intermediate to resistant. What I will say is that there's this small set of data suggesting that this is a therapeutic option, but also there's a significant amount of increased adverse effects associated with pushing the doses of the Posaconazole. So if it's going to be done, it needs to be done with very careful therapeutic drug monitoring, not just from a level standpoint, but monitoring for toxicity. Okay, last azole is Cresemba, Isavuconazole. Similar susceptibility profile to Posaconazole in terms of activity against Candida, Aspergillus, and mucormycosis. Isavuconazole sodium is a water-soluble prodrug, which is rapidly cleaved to Isavuconazole, which is the active metabolite. And therefore, the active agent, we do not need a cyclodextrin solubilizing agent. This drug The dosing seems weird. 372 milligrams of isavuconazole sulfate 3 times a day times 2 days, and then 372 milligrams daily. That's because every 372 milligrams of the salt is equal to 200 milligrams of isavuconazole, and that's the way the FDA wanted them to label it. Even longer half-life, absolutely need that loading dose. You're going to be waiting weeks for therapeutic drug concentrations. Otherwise, it's not dependent on PO intake for absorption. It does have reduced clearance with hepatic dysfunction, but you're going to need to monitor levels for that because we don't have good guidelines. CYP3A4 inhibitor, although less so than Voriconazole or Posaconazole, is considered a moderate CYP3A4 inhibitor, so more like fluconazole. This is a potential niche, especially if you have an investigational drug that is contraindicated in combination with potent 3A4 inhibitors. It has a modest QTc shortening effect, which makes it different from the other azoles, so we're less concerned about it in patients who have QTc prolongation to begin with. We don't want to shake or send this via tube, as that could cause the prodrug to convert to isavuconazole pre-vivo. So isavuconazole studied in comparison, randomized study with Voriconazole for Aspergillus and other filamentous fungi, and had equivalent efficacy, and equivalent all-cause mortality compared to Voriconazole, both in the intent to treat group and the modified intent to treat group, which was specifically for Aspergillus. Very, very similar response rate, similar to Posaconazole, slightly less side effects than with Voriconazole. And also, Ribavirin actually has FDA approval for the treatment of mucormycosis based on 37 patients with a 35% mortality rate. And this was compared to historical controls with amphotericin B and found to be very comparable. So this just kind of shows you how much help we need with mucormycosis. Switching over to the Echinocandins, they inhibit synthesis of beta-1,3-D glucan, fungal cell wall, fungicidal against Candida, but fungistatic against Aspergillus. Since there's no equivalent component in mammalian cells, they tend to be well tolerated. Casmofungin or Quilitz was our first one, approved in 2001 for esophageal candidiasis, candidemia, disseminated candidiasis, salvage therapy for invasive aspergillosis in patients who are refractory or intolerant, and for persistent neutropenic fever. Usually dosed at 70 milligrams a day, then 50 milligrams, 70 milligrams day one, then 50 milligrams the day after, unless it's given in combination with enzyme inducers, then 70 milligrams a day, potentially dose reduced in patients with hepatic impairment. Drug interaction noted with cyclosporin, mostly increased LFTs. Micafungin was the second one, FDA approved. It's one we have on formulary at Moffitt. It does have manageable side effects with sirolimus and nifedipine, which can be monitored, but it is free of drug interactions with most of the agents that we're going to use in our transplant patients or our acute leukemics for that matter. It's FDA approved for the treatment of esophageal candidiasis at 150 milligrams a day, prophylaxis of candida infections in stem cell transplant patients at 50 milligrams per day. We use 100 milligrams per day in our acute leukemics when we use it for that purpose. So we see some breakthroughs with prolonged neutropenics. For candidemia invasive candidiasis, 100 milligrams of micafungin is comparable to 150 milligrams of micafungin, which is comparable to casmofungin. It's been used as salvage therapy or combination therapy for invasive aspergillosis, typically at 150 milligrams per day. We don't need to load, and we don't need dose adjustments. Cidofovir, third approved Echinocandin. Initially, the prescribing information recommended reconstituted with 20% dehydrated alkaline water, which there were concerns about alcoholic patients or patients who were Muslim or drug interactions with Echinocandin, but now thankfully they proved we can use sterile water. Cidofovir undergoes slow chemical degradation under physiological conditions, so it's not dependent at all on the liver for its clearance. And it's approved for esophageal candidiasis and candidemia candidiasis. And it has been used in combination with Voriconazole for invasive aspergillosis, specifically this study, which did not show statistically significant difference in week 6 mortality using Voriconazole plus or minus Echinocandin. Post-hoc analyses did suggest that patients who are galactomannan positive from serum or BAL might have a better response. And the newest one is Ribavirin, which has a prolonged half-life of about 150 hours. Patients receive 400 milligrams IV times 1 and then 200 milligrams IV once weekly thereafter. And really, the role for this drug currently is in patients who are going to need prolonged echinocandin therapy for azole-resistant disseminated candidiasis. We have not yet added this to formulary. It is being studied as antifungal prophylaxis in allogeneic stem cell transplant patients as well. So we'll wait that. Candidate adverse effects, as I said, usually well tolerated. The most common adverse effects we see are LFT elevations, but they're less common when compared to azoles. Rare histamine-related infusion reactions, but it is important to know that there are rare case reports of cardiac decompensation following administration of caspofungin and inidrolfungin, but not microfungin or resofungin so far, possibly via mitochondrial damage. And there's concern that there may be a mechanism of toxicity may be similar to Echinocandin-induced heart failure. So rare, but potentially severe. Of note, resofungin has been reported to cause photosensitivity during therapy and for up to 30 days thereafter due to its long half-life. So at this point, I'm going to switch from our antifungal drugs, and I'm going to talk about viral infections of cancer patients, where antiviral therapy may have a role. And I will say that when I started thinking about this, I'm like, well, all of the antiviral drugs are potentially used in oncology patients because we have an immunocompromised patient population. So what I'm going to try to do is kind of focus on those agents that we most commonly use and that are predominantly going to be used in an oncology patient population or other highly immunocompromised patient population. All right, so I'm going to, so obviously we're all very familiar with herpes simplex virus and varicella zoster virus. Just to quickly go through these, right? Acyclovir, mechanism of action, acyclovir triphosphate inhibits viral DNA polymerase. We use it for prophylaxis in high-risk patients at 400 to 800 milligrams twice a day. We see some breakthroughs caused by the fact it's only 10 to 20% bioavailable. And there's IV dose, IV dosing like 125 to 250 milligrams per meter squared, IV BID if the patient can't take oral. For HSV infections, for a serious infection, you want IV acyclovir. You can't trust the oral bioavailability. For HSV, 5 milligrams per kilogram, IV Q8. For VZV, typically 10 milligrams per kilogram, IV Q8, up to 15 milligrams per kilogram if you're dealing with a CNS infection. For obese patients, early information recommends dosing by ideal body weight. There's also some more recent information suggesting adjusted body weight might be an option, and I would especially consider that if treating a severe infection, particularly the CNS infections. High-dose IV acyclovir can be nephrotoxic, so patients need to be adequately hydrated, and we need to adjust dosing at renal dysfunction. Valacyclovir is a prodrug for acyclovir. It's about 55% bioavailability. And so this is a superior option for treatment of HSV or VZV with the doses you'll see there. Famciclovir is another perfectly appropriate option. It's a prodrug for penciclovir, which has very similar activity to acyclovir, but it's not available in the US. And I'm going to move on, talk a little bit about cytomegalovirus and HSV6 first-line therapy. right? So both ganciclovir and foscarnet, again, in the triphosphate form, inhibit viral DNA polymerase. Typical dosing for ganciclovir is 5 milligrams per kilogram IV Q12, dose adjusted for renal insufficiency. And the dose-limiting toxicity is myelosuppression. We can see CMV resistance. That's very rare in previously untreated patients, but patients who require multiple courses of ganciclovir therapy becomes more and more common. We have valganciclovir, which unfortunately sounds a little bit like valacyclovir, but it's an excellent oral option for these patients because it's about 60% bioavailability. Then we have foscarnet phosphate, which when used for CMV and HSV6 infections, the dose is typically 90 milligrams per kilogram Q12 or 60 milligrams per kilogram IVQ8. It has it's a nephrotoxic drug, causes a lot of electrolyte wasting, can cause general ulcerations in females. Normal saline, aggressive hydration, necessary to reduce nephrotoxicity. We do have to adjust the dose for renal insufficiency, no oral option here, and we try to reserve it for those patients when we're treating CMV, patients with baseline neutropenia, or they have ganciclovir resistant disease. And it may be superior to ganciclovir for HHV6B encephalitis, so that's a role. It's also used for acyclovir resistant HSV infections, although you can use a lower dose of 40 milligrams per kilogram Q8 to Q12 hours, depending on the severity of the infection. And for CMV pneumonia, there's some data suggesting that adding an immunoglobulin combination may be helpful. We now have Letermovir for CMV prophylaxis, which is which inhibits CMV viral terminase complex, and 480 milligrams a day, starting between day 0 and day plus 28, continuing through day plus 100. Available oral and IV. Reduced dose with cyclosporin. No renal or hepatic dose adjustments. Most actually very well tolerated compared to other agents that we have. Nausea, vomiting, diarrhea are the most common side effects, GI side effects. And what we can see is that we can significantly reduce the incidence of clinically significant CMV infections in both high and low risk groups. And while there's some separation in the mortality curves through week 48, it's not statistically significant at that time point. However, what it can do is save a lot of very unpleasant infections in patients. What we can do in these patients is typically monitor a CMV viral load weekly by PCR. And so Letermovir is going to help us have to treat those patients far less often, treating those patients to avoid viremia progressing to full CMV disease. And we use Letermovir specifically in seropositive recipients who are receiving cord blood, haploidentical T-cell depletion mismatch, ATG or alemtuzumab, or post-transplant cyclophosphamide, which we use quite a bit of. And as I mentioned, continue that 3 day plus 100. Weekly CMV monitoring during the period of prophylaxis, and we have to continue acyclovir as well, because it's not active against HSV, VZV. Cidofovir or Vistide is used for adenovirus, which can cause hemorrhagic cystitis in these patients, or disseminated disease. BK virus, which can cause hemorrhagic cystitis. It's also active against CMV, HSV, or VZV, though it's not our favorite drug for those. It also inhibits viral DNA synthesis. It requires hydration and promethazine to reduce nephrotoxicity risk. It also has potential for myelosuppression and ocular complications, including iritis and intraocular hypotension. There is some data suggesting, mostly in pediatrics, that 1 milligram per kilogram 3 times a week may be less nephrotoxic than 5 milligrams per kilogram per week, so we tend to use that dosing. For BK hemorrhagic cystitis, you can use low doses of 0.5 to 1 milligram per kilogram once per week without probenecid. And most recently, we have Ribavirin, which is approved for post-transplant treatment refractory CMV infection or disease, so either proven resistant or just treatment refractory. And patients have to have failed at least one of the active agents that we just discussed. And what they found was it was about 40% effective at the end of study week 8 versus 29% for investigative assigned therapy. It is a CMV UL97 kinase inhibitor. It's not active versus HSV or VZV. It may antagonize activity of ganciclovir, so it should not be used in combination. It's available orally, 400 milligrams twice a day with or without food. Higher doses are needed in combination with carbamazepine or benzoyl or phenobarbital. It can be administered down an enteral feeding tube. It is a 3A4 substrate. It's a weak 3A4 inhibitor. Taste disturbances are the major complaint in about 46% of patients. And they do resolve after discontinuation in about 89% of patients. Usually takes about 6 days to resolve, but a range of 2 to 85 days has been reported. Then a wrap up with Ribavirin. As you know, Ribavirin is FDA approved for treatment of hepatitis C and RSV in children. It inhibits RNA polymerase activity and also inhibits the initiation and elongation of RNA fragments. This prevents viral protein synthesis. The mortality benefit in immunocompromised adults is unclear due to lack of prospective randomized clinical trial data. We do know that's highly teratogenic based on animal studies, and isolation is required for nebulized therapy. Nebulized therapy is kind of going the way of the dodo because you need to administer it over 12 to 18 hours or 3 times a day over 2 hours via SPAG tube generator. So you need a special nebulizer. It costs now about $20,000 a day, so about $200,000 for typical 10-day duration of therapy. And you have to have extensive exposure precautions to prevent women of childbearing age from being potentially exposed to this chemical. Patients can experience bronchospasm and dyspnea. So oral ribavirin has more recently been studied. Again, not in, mostly just compared to nebulized therapy. And it's available in 200 milligram tablets. Our dosing is there for you. So a 10-day course of therapy costs about $160, which is a little different from $200,000. It does have, it can cause hemolytic anemia and less commonly hepatotoxicity. It does need to be dose reduced for renal dysfunction. We consider it in patients with hematological malignancies and central stem cell transplant recipients with RSV upper or lower respiratory tract infections and moderate to severe immunodeficiency based on the criteria that you see below. We do need to monitor it carefully. Particularly for hemolytic anemia, we look for a CBC with differential, CMP at least 3 times per week throughout oral ribavirin therapy, whether it's IV, inpatient, or outpatient. Patients who are hypogammaglobulinemic, we will supplement that. We typically treat these patients for 7 days, but longer durations of 10 to 14 days may be required for patients with lower respiratory tract infections. Okay, I'm going to go ahead and wrap up here. I will just mention that hepatitis, that some of our patients are at high risk for hepatitis B reactivation and may require Hep B reactivation prophylaxis with entecavir or Cidofovir. Mostly are allogeneic stem cell transplant patients and patients receiving drugs like anti-B cell treatments like rituximab and Campath, for example. Hepatitis C therapy can be administered currently or sequentially with cancer chemotherapy. HIV therapy needs to be treated if the patient's diagnosed with a malignancy concurrent with HIV. therapy. We initiate HIV therapy as soon as possible. And then our patients are going to be high-risk patients from a standpoint of COVID-19, which we are using Paxlovid when possible to reduce the risk of progressing to severe disease, or the 3-day remdesivir for those patients who have too many drug interactions. Not a lot of excitement about Lipid given its reduced efficacy rates. And we do use, for treatment of severe, we certainly do use remdesivir 5-day in combination with dexamethasone. And we also, for our influenza patients, we use Tamiflu. So I'm going to go ahead and stop there. I have time to take any questions before Dr. Green presents. I'm happy to do so.